Nice to see everybody. My name is Helen Crimlisk. I'm Deputy Medical Director here in Sheffield Health and Social Care Trust. I'll introduce my colleagues to you in a second from SHSC, and we're going to talk through a presentation of about 10 to 15 minutes maximum, and hopefully leave plenty of time for questions from individuals. James, would you like to put the PowerPoint? Oh, so let me just say hello to who we are first of all. So yeah, that's me. And then we've got Ashritha. Where are you, Ashritha?
She doesn't appear to be on the call just yet. I have spotted some people, both Ashritha and Jonathan. There was a placeholder link. I think they've just tried to access on that one, but Mel's said about the link. We've just put it in the chat, so hopefully they will be here momentarily.
Okay, and there's more people arriving now as well. So let's just see. We were talking 2 minutes ago. I know they're around. Well, perhaps we'll, and James and Mel, do you know everybody or do you want to say hello?
Mel, after you.
So good evening, everybody. My name's Mel Hall and I am Head of Service for Primary and Community Mental Health. I work for Primary Care Sheffield and I have an honorary contract with SHSC. My role is around the delivery of the business as usual. So hi, everybody, and thanks for making it tonight.
And good evening, everyone. For anyone that I've not had the pleasure of meeting, I'm James Sutherland. I'm Head of Primary and Community Mental Health Transformation. So I work across SHSC, PCS, support across the 15 networks, and also work with the voluntary sector. And I do that 4 days a week, and 1 day a week I work with NHS England as within the National Adult Mental Health Team as a national advisor on community mental health transformation. Hopefully my long intro has given a little bit of extra time for Ashritha and Jonathan to join.
But we haven't seen them yet. And Lindsay and Lucy, do you know everybody here, or do you?
I think I know most people. I'm Lucy Cormack. I am here as Medical Director of Primary Care Sheffield.
James, can you put the slide up? Sorry, Lindsay, please go ahead.
Sorry, I was going to say hi. I'm Lindsay Hughes. I'm Director of Operations at PCS.
So, James, do you want to put that PowerPoint up and we'll get going?
Certainly. Just
so first thing I'd like to say as that's going up is that I'm Deputy Medical Director here, but my background is entirely in community mental health, really. I was a consultant at Eastglade for a long time. My clinical work more recently has been in EWS, and I feel like I've been involved in projects across the primary secondary boundary for some time. So next slide, please, James, thank you. So and the next one, please, and we'll work our way through here. So the first thing to say is the context for this, and just very briefly, the Community Mental Health Framework is a national programme for England. Next slide, please. It's linked to the long-term plan and the investment that came with that for the CMHF, the Community Mental Health Framework for adults and older adults, and that's what the programme is delivering. Sheffield was an early implementer for this, so we're a little bit ahead of the curve compared to other parts of the country, and I know as James does in other areas, lots of people are struggling with this at the moment. It's a new way of working for all of us. Just to remind people, the main aims are to improve access and care and treatment closer to home, aligned to the new concept of PCNs, and very much in partnership with our third sector partners, in our case, Mind. It's a core offer to each PCN, but informed by the particular population needs of your area and ability to sort of flex with that. And the focus is on SMI, serious mental illness, but as has been discussed before in forum, I think we're trying to take a sort of flexible approach to that. SMI means different things to different people anyway, but we're trying to be flexible, but it is focusing on the more severe end of mental illness. What are we going to do as part of this? So offering more psychological therapies around psychosis, bipolar, complex mental health problems, thinking about ways of addressing physical health and that 20-year mortality gap that we've got, thinking about it being needs-led, not necessarily dependent on diagnosis, personalised and trauma-informed, medicines management support and employment support. So a whole range of different options. Important to think about what the outcomes that we're looking for. There's a whole set of those defined by that, but I think really importantly and crucially for me, service user experience. We want less moving around and less passing around as service users, clearer ways of moving through the system, fewer people on waiting lists, closer to home care, and less variability, particularly that which we know relates to the inequalities agenda. But also important to think, I think there's benefits that we really want to achieve for general practice colleagues as well. The experience of the relationship with secondary care, better access to advice and support, a variety of responses rather than the sort of on-off response, which you sometimes feel that you get from us enough. So with the options of consultation, advice, having a say in how you want to use this resource and really having a lot of control over that. Next slide, please. So the future mental health service system will look a little bit different to what we've got before. I've been around long enough to remember when talking therapies, or what we used to call IOUT, was introduced. It was an absolute revelation initially and really very valuable, but we're moving on from that now and now offering this ability to sort of treat more people with mental health problems in the community and particularly in collaboration with the BCS. So breaking of some of the traditional structures. I like to talk about it as being a sort of blurring of the boundary between primary and secondary care, which is why we're trying to work very closely together with primary care Sheffield. Next slide, please. Yes, it does say at the bottom there, you know, this is a start. We're hoping this is going to start within the next few months, but it's not going to launch as a fully fledged operational system which is working perfectly, and we know that we've got more work to do in the future. The CMHF describes that. It talks about eating disorders, personality disorder, older adults, and of course increasingly all of us having to work with the challenges of managing people with neurodiversity. Next slide, please. So this is just an opportunity to talk about what we've heard from you and how we have devised the medical offer based on that. Next slide, please. So we know that these are the things that you've been wanting, thinking about looking for more support, advice, information, less of that sort of on-off response, a better time frame than any of us would want to see. And I just want to acknowledge here that we know we've got a problem here. We currently have 230 patients awaiting a medical review within EWS. We are very actively trying to manage this backlog at the moment with additional investment so that when we start our new system later on in the year, we have got as much capacity as the new programme needs us to have. Just to acknowledge as well that the CMHF, like lots of the other NHS plans at the moment, focuses on different ways of doing things. That's why it's called a transformation, and it includes the use of new roles. And we do have people in new roles within the system, all in many different roles. But within this medical space, we're really lucky now to have the pharmacists who are doing a lot of the prescribing work and supporting prescribing and medicines management. But we're also wanting to think about new roles for GPs as well. And one of the things that we're going to be talking about is a GP with extended role type of approach, again, to support that sense of working together and developing the expertise. I'm not quite sure whether my colleagues have joined yet or not.
Yes, Helen, I was just about, sorry to interrupt the flow. Jonathan and Ashritha have been able to join us now. Would it be worth just Jonathan and Ashritha introducing, and I think this is the handoff point for Ashritha so perfect timing to hand over to Ashritha. So maybe if Jonathan introduces himself, Ashritha can, and then we'll move on to Ashritha leading.
Okay, hi, sorry, I had the wrong diary invite, so I couldn't get in. So my name is Jonathan Mitchell. I'm consultant psychiatrist and clinical director in SHSC.
Good evening, everyone. I'm Ashritha Roy, and I'm a consultant psychiatrist and clinical lead for community services, and I'm also leading the transformation work. Okay, thanks, James. I think I've seen and met some of you in some of the engagement events, and some of you are already aware of what's been proposed and what we are working on. And based based on that, we have come up with this offer, and I'll talk you through over the next couple of slides. James, do you want to move, please? Thank you. Okay, so sorry I missed the earlier slides because I just couldn't get in. I had to register again. Not sure why that happened, but anyway, here I am. So this psychiatric medical offer that we were talking about, which Helen was introducing you to, is a team of doctors, including trainees, who will be able to support our primary care colleagues, including GPs, with, say, for example, over here on this slide is medication advice. So say you've seen someone in your clinic with NSMI, say bipolar, and they've been on medication for a good 6 months and now they're relapsing. So you need just advice on that medication. So you'd be able to arrange for a phone call, a 15-minute professional call, to discuss the case, discuss the medication, and receive advice on how to follow this patient up and what you can do with this patient. And then similar with diagnosis. So you're not sure of the diagnosis, so you would like some advice, then you're able to do that. Similarly, for risk issues, I know some of you, pretty much all of you, are managing quite a high level of risk already in primary care. And if you need support with that or advice about where this patient might sit, how you might manage this patient, or would you like to have maybe some advice on where's the right place for this to be referred, then you can have that discussion on risk as well in these phone calls. Next one, please, James. Then ongoing management. So I'm sure you have SMI patients who have exhausted all kinds of treatments and interventions, and you need some advice. So that also is an opportunity that you can have in these consultation appointments. And a relocation to Sheffield. A lot of times they are referred both to the GP as well as to some of the secondary care services already. But if it comes solely to you, then you can have some advice regarding that as well. Next slide, please. Okay, so the medical pathway, the next slide, James, please. So this slide, please don't worry if you can't get your head around all of this. You will have this in the survey, so you'll have more time to think it through and respond and respond to the survey. That'll be helpful for us. So basically, this is what you would do if you find a patient who has risk and you've seen them in the clinic and you want advice, or you know where to go. So if you triage the patient and you think they need a response from 0 to 72 hours, then you refer them to urgent and crisis team. So they will handle that call. And then if they don't need a 72-hour response and longer, then you decide whether they are open to any mental health team. If they aren't open, if they are, they're straightforward and you contact the team and job done. If they aren't, then if they're discharged in the last 6 months, then you can refer them back. But if they've got no support, and they need PCMHT support, then they can be booked in via the PCMHT referral system 1. It's a straightforward pathway to follow. And then you've got, as I said in the previous slides, you've got opportunity to discuss for advice, risk, medication as well. The psychiatrist can book, it could be GP with excellent roles, they can book you up for about 60 minutes, depending on what they need to do, or have up to 3 of 30-minute follow-ups. So yeah, this is basically a way to escalate things, and so it's easy to read. Next slide, please. Okay, I'm going to finish this now. We are hoping to finish the presentation quickly so that we have an opportunity to have questions and a conversation and dialogue. So I'll pass it on to Mel now.
Thanks, Ashritha. So next slide, please. So the question we're asking is about how does this link into the wider PCMH programme? So this isn't about how does it link into wider secondary care mental health. I'm specifically talking about the teams that you have within your primary care networks. What this slide is trying to draw out is that those three different circles come together, where you've got the support for the from the psychiatry or medical team to the PCN specifically. So that's where it's that you only are asking for psychiatric, for the medical support. The next is where there's a general practice and they're already under the primary care mental health team. So that's section 5. And then, of course, the medics office are also supporting the nurses, social workers, pharmacy, the wider team that's already attached to your primary care network. What we also see in the slide 4, in section 4, is that there is a direct link between the pharmacy team that's across the city, which work in a portfolio approach, but your pharmacist will work directly with the medical team, which we're describing. So I'm trying to see is that there's a lot of different options, but it's embedded. The medical team are embedded into the primary care mental health offer, but not but also with the PCN as well. So one is not that you have to be under a psychiatric, under the team. Let me just go to the next slide, please. And hopefully, so I know many of you have seen this already, and I do recognise it's confusing if you've not seen it before. But if we take the first section, what we're saying is we know that you know when you have reached your knowledge around a medical prescribing or diagnosis. And in a response to that, we have not used those booking slots for the psychosocial. So you don't have to be with a psychiatric nurse to be able to have a medic. We put those two things as separately so that team supports the MDT, which is the PCMH, as well as primary care, your practice as well. So thank you very much. I'll move to the next slide.
Thanks, everyone. I'm afraid you've got my dulcet tones for the home straight. So appreciate we've been through a lot of information. These slides we will circulate as soon as possible after this meeting. There's a handout pack that has had a bit more information in as well. We really want to hear your feedback on the proposed model. Over the last 12 to 18 months, we've heard from GPs and primary care colleagues about some of the wishes, the desires, wanting to see a different approach, a different system. And equally one that's flexible as well, in terms of acknowledging that as GPs, as independent practitioners, prescribers, we've heard from some GPs that may wish to initiate medication themselves with the support of a psychiatrist. Others that say, no, I don't want to do that. I want the psychiatrist or the medical team to be able to support there. So this is more flexible. You'll see a QR code on screen and also a web link to SurveyMonkey. Launching today, running until the 11th of February, is a survey that it'll take about 3 minutes to complete. There's 7 questions. The pathways, that vignettes of support offers are all summarised on there, so you can see them a lot bigger than what you could on this presentation. We're really keen to use this as a playback to say, based on the feedback as primary care, do you recognise the changes? Do you feel this is appropriate? What do you think's good? Is there anything that we're missing? After we've done that, after the 11th of February, we then want to be able to then consolidate and be able to really start to progress to move this. But hopefully people will see things and a model that they can recognise their feedback, their asks and their wishes in there, and something that looks very, very different and transformational to what we have today. I think it's probably fair to say, following the model, a lot of the primary community work we're aiming for April this year. I think the medical offer, because of some of we may need to do some recruitment and other bits, that might follow on so slightly after April. So we've badged it as during Q1. One really important thing as well is all of us as partners in mental health and with you as primary care colleagues working as one, we know this is a new way of us collectively working. And we know that we're going to need to work closely over the coming months to really understand what the demand is. So how many initial telephone consultation slots do we need versus how many follow-ups? Where might there be educational support that we identify that's needed to work with some practices? It's probably going to take us 12 months to calibrate this offer, to work together and to collectively get it right. It's markedly different. None of us, I don't think, can actually predict how many of an initial 15-minute slots, how many lots of 30. This is where we acknowledge it's not going, it'll be 80% right, hopefully on day one, but we want to work collaboratively with you to be able to shape that over the coming months, and how we learn, how we move forward, and how we make this into a really, really exciting and hopefully value-adding component to our primary care and secondary care systems working together in Sheffield.